appreciate the invitation. I'm sorry I couldn't be there. I was really looking forward to not only listening to the lectures, but the camaraderie at the sessions and at the meals. But I'm there in spirit, and I hope I'm able to share some interesting observations regarding where we are in understanding the crosstalk between the immune system and the central nervous system. So Dr. Green gave a great introduction, so I'm just going to move over to these are my conflicts of interest, which will not play into this conversation. And let's start from what our bodies are trying to do on a daily basis when it comes to defending against potential incoming dangerous substances or entities. Just talking about how we're now phrasing how we do surveillance in the form of using the term interactome, which is talking about the crosstalk between the somatosensory network and the mast cell compartment, and then how this might be impacting, leading to injury of the central nervous system via neuroimmune mediated injury. So when I first entered medical school, that's when scientists identified the relationship between immunoglobulin E and mast cells. And that was actually at the crux of this new epidemic before we had COVID, and that was immune hypersensitivity disorders. We saw a huge increase in rhinitis, anaphylaxis, atopic dermatitis, asthma, to the point that peanut butter and jelly was replaced with potato chips in schools. Anaphylaxis now impacts 1 out of 50 Americans. So this is a huge problem, and we're trying to understand what led to such an upsurge of immediate hypersensitivity disorders. Because of the observation at National Institutes of Health linking IgE to mast cells, basically most allergists would do is if you came in with any of these complaints, they would just test you, either skin testing or blood testing, and then potentially offer you allergy shots if it was environmental allergens, and then they would repeat. So literally, they kind of dumbed down the actions of mast cells to just whether you had IgE to it or not. I would have to say, starting in 2004, 2005, I started seeing an upsurge of patients who were having immediate hypersensitivity disorders. And again, it was not explained by IgE sitting on mast cells. And this is the epidemic that we were seeing. 4 out of 10 children, up to 30% of the adult population. Up to 30% of the adult population. Close to 1 out of 10 have asthma. 2% of the population are dealing with atopic dermatitis. Food allergies, urticaria, as well as anaphylaxis are on the rise. So now, with the new technologies, we're starting to identify other receptors on mast cells besides the Ig receptor. And I think what's going to be really important in the next coming months and years is the role of complement contributing to mast cell activation. But up to this point now, by 2024, we've identified a series of receptors that are responsible for causing mast cell dysregulation and chemical mediator release, and also including the crosstalk between mast cells and the nervous system, which a lot of people appreciate in the form of migraine medications. CGRP is actually a direct mast cell degranulator as well. So instead of using the term allergies versus not allergies, we're going to use the term mast cell activation disease because it's just trying to identify whether or not mast cells are actually contributing to the signs and symptoms that people are experiencing, whether we're talking neuropsychiatric issues, peripheral neuropathies, gastrointestinal distress, pruritus, flushing, itch, joint pain. And so in 2010, allergy immunology specialists as well as hematologists, oncologists on both sides of the pond put forth a new criteria called mast cell activation syndrome. And it was finally, and although it was put forth in 2010, even the general allergy immunology community really didn't start to embrace it until 2019. But this is how we define it. Do you have signs and symptoms of mast cells misbehaving in any one of these 5 organ systems? Are you able to get better with medications that target mast cells or some of the chemical mediators? And then lastly, what data do you have to support that the mast cells are actually contributing to your symptoms? So really, it's these signs or symptoms, these medications, and do you have data that backs up the story that you just told? And then once you secure the diagnosis of mast cell activation syndrome, you then want to figure out why your mast cells misbehaving. Do you have mast cells that have a broken receptor, such as systemic mastocytosis, or more recently identified hyperalpha-tryptosemia? Or Are your mast cells breaking bad because you've made antibodies against cat and food, or you have an unidentified infection, or a brewing lymphoproliferative or a neoplastic disorder? And then also we're finding a large number of individuals are actually susceptible to physical triggers. And again, this kind of reflects that somatosensory mast cell crosstalk, whether you're talking vibration, pressure, heat, wavelength of the sun, can cause mast cell degranulation because it first goes through the somatosensory network, which then pushes the mast cells to release the chemicals. And lastly, mast cells can be a victim of a mutiny within the immune compartment with developing autoantibodies that target IgE or the receptor on mast cells, as well as their blood-borne cousins, basophils. So you've secured the diagnosis of mast cell activation syndrome or MCAS-ish, because sometimes it's very challenging to get the data to support that. But it's still also really important to make sure that there are not any other conditions that can mimic mast cell activation disease or may be potentially driving the mast cells to release these chemicals inappropriately. And the two that I would like to highlight out of this list of conditions is postural orthostatic tachycardia syndrome. This was a disease cluster that was first discussed almost 15 years ago. And now there's more data kind of reflecting, again, if you have autonomic dysfunction, here's that somatosensory motor neuron crosstalk with the mast cell compartment causing chemical mediated release. And also we have autoinflammatory disorders where you actually have problems with the connective tissue itself that sends out danger signals, and then the mast cells and the nerves get recruited intact. So to give you an example of one patient that kind of opened my eyes, kind of forced me to re-educate myself because I'm a T-cell biologist by training, I had to learn about mast cells because this young boy came to see me and I was the 11th allergist. And you can see by the list of other practitioners that this child had seen before his mother, Tina, brought me into this office. He literally was seen by nearly a dozen allergy immunology specialists, pulmonary, nutrition, genetics, and no answers to his food intolerance, susceptibility to anaphylaxis, asthma, neurocognitive regressions, and joint pain. And he was repeatedly tested for organic or primary mast cell disease, and none of the tests were helpful in identifying what was going on with him. So this was kind of his odyssey when I finally met him. And then basically what happened was primary care thought it was allergy, ENT thought it was allergy, endocrine thought it was allergy, pulmonary thought it was allergy, cardiology thought it was allergy, derm, germ, gastroenterology, orthopedics, and genetics. The only people who didn't think it was allergy were the allergists. So the question is, okay, if it's not allergy, what else could be producing these signs and symptoms in this individual short of that IgE positive allergen test? And so when we asked these questions of him, and yes, he did meet the criteria of having immediate hypersensitivity events, we just didn't have the data to suggest that it was a primary mast cell problem. And because our objective data is somewhat lacking in identifying MCAS, we have to kind of lean into, let's give him some therapies that will give him some symptomatic relief. So avoidance, use of histamine blockade, leukotriene blockade. And that allowed us to pursue other avenues of investigation, whether or not this was primary mast cell activation disease or was this a form of secondary mast cell activation disease. And this is the type of workup that I typically do for every patient that comes through my door saying I have mast cell or I'm reacting to the world. And I'm gonna just leave this. I've submitted my slides, and so I'm more than happy to use those as a resource. But the bottom line, Sean had an unidentified heritable disorder of connective tissue. His mother was tall. He was tall and lanky. Matter of fact, the first time I met him, he was sitting on the floor in a W and was able to twist his spine. And so here was my first patient who said, okay, I must understand why his nerves and mast cells might be misbehaving, contributing to those type of symptoms. And so he had hypermobile Ehlers-Danlos syndrome, and understand there were 6 variants of EDS that were described until 2017. And so the biology is just catching up with how these patients are presenting. And so one of the first articles that I was able to find talking about this crosstalk about mast cells and hypermobility or heritable disorders of connective tissue was an article by Dr. Marco Castori, who has been a geneticist involved in the EDS world for close to 15 years. And he had noted that individuals that were hypermobile, like this mother and son that I had cared for in the early days of my private practice, were hypermobile, but they were presenting with immune dysregulation and primarily signs and symptoms that were worrisome from mast cells misbehaving. And so up to this point in time, mast cells are not just allergy cells. And to try to give you the power of this immune cell, this is a cell that's been found in all types of species, as low as shellfish. They have the ability to release chemicals that can directly inactivate toxins, can recruit and activate other immune cells, can modify the connective tissue, and also modify blood flow with the use of heparin, VEGF, as well as platelet activating factor. So in many ways, these mast cells are regulatory cells with the ability to not only coordinate action within the innate immune compartment, but also in the adaptive immune compartment as well. So far from a one-trick pony. And again, just to give you an idea of the crosstalk between the different cell populations. So you have ecdysons, prostaglandin metabolites that crosstalk between the somatosensory, the peripheral nervous system. You have the ability to talk to T cells and B cells, endothelial cells, and also adjust connective tissue as well. I'm not the first person to think about this. Actually, the earliest observation of allergen-driven mast cell activation disease was by Professor Schneerson back in 1977 when he published. He found that 11 subjects either had Marfan's, neurofibromatosis, or Fragilis ostium were much more likely to have atopic disease compared to patients that had scoliosis. This is a report out of University of Cincinnati that showed that if you had any evidence of a connective tissue disorder, Marfan's, Ehlers-Danlos syndrome, or osteogenesis imperfecta, you're much more likely to have eosinophilic gastrointestinal disease. And this was in 2012. We had efforts both in the veterinary world and out of Russia that were able to identify mast cell dysregulation in individuals that had connective tissue disease. But again, this was all circumstantial evidence. There really wasn't anything leaning into, well, what exactly is that relationship? And so I just wanted to point out that Dr. Symes is a veterinarian who's just pondering why he was seeing certain breeds of dogs much more likely to have musculoskeletal issues, blowing out discs, having heart murmurs, having immune-mediated diseases, food intolerances. And there was some seasonality to it, as my brother, who had an Old English Bulldog, ruptured 2 cruciate ligaments in the beginning of spring and had no problems during the winter and fall. So this is just, again, highlighting that this is a issue with our environment that's not only impacting humans, but cats, dogs, horses, and any of our veterinary participants in this meeting will appreciate that these connective tissue issues were not an issue prior to maybe about 50 years ago. So these are just some of the reports that I had put forth back in 2013, my first observations of crosstalk between the mast cell compartment and the nervous system in individuals that had hypermobility. So the model that we're now kind of embracing is, if you think about how our body tries to function on a moment-to-moment basis, it is the crosstalk between the nervous system and the immune system within the connective tissue that's facing an environment that is now presenting with a lot of challenges that the immune system is just not prepared to handle. And just to give you an idea, this was just a retrospective study that I had performed out of patients that I had seen between 2015 and 2019. We just looked for whether or not they had evidence of mast cell activation disease, did they have evidence of neuropsychiatric issues, did they have evidence of immunodeficiency and autoinflammatory issues. And what we found that is 1 out of 5 of these individuals had evidence of mast cell disease, heritable disorders of connective tissue, as well as immunodeficiency syndromes. And the top 3 complaints of these patients were gastrointestinal distress, neuropsychiatric issues, and respiratory complaints. These are individuals that had mannose binding lectin deficiency. And again, top 3 complaints were GI, respiratory, and neuropsychiatric as well. And this is just the data. I'm sorry, the slides got switched, but I wanted to point out the fact that once you break down what these patients were dealing with and ascribing syndromes that may be contributing to it, again, it's this triad of the connective tissue and the mast cells and the nervous system that is askew, that's leading to increased release of chemical mediators in the mast cell compartment that can modify the connective tissue. And then the question is, if this inflammation is ongoing, are there vulnerable parts, for instance, of the spinal cord that may be at risk for physical trauma causing recurrent inflammation and weakening the structural integrity of those locations in the spinal cord? The most direct evidence that we have that an immune issue can cause problems, global connective tissue issue, is the 13th variant of Ehlers-Danlos syndrome, which was first reported in 2016. And what was really interesting is, unlike the other forms of Ehlers-Danlos, variants of Ehlers-Danlos syndrome, other than hypermobile Ehlers-Danlos syndrome, peridontal EDS was due to a gain of function in the complement system. So here you have a protein system that is as ancient as the mast cells, that operates in the innate commune part dealing with the environment, that has the ability to change the connective tissue. And interestingly enough, C1 has been actually shown to have direct activity on the central nervous system as well. And more recently, some work out of Medical University of South Carolina with doctors Norris and Gessimer identified that kallikrein receptors, again, part of the complement system, are now a strong link to individuals that have hypermobile Ehlers-Danlos syndrome. So now you have this crosstalk between the nervous system and components of the immune system that are causing global connective tissue issues. And those global connective tissue issues may predispose certain parts of the connective tissue to be essentially Achilles heels or weak links that can be more compromised by ongoing inflammation. So why are we seeing such I would say, an uncovering of individuals that are susceptible to this triad? We really have to kind of look to the way we are now living. And I tell patients who come through all the time, it's usually families, I ask the parents, clearly the world that your kids are growing up in were different than what you grew up in. And clearly the world that you grew up in was different than what your parents grew up in. And it is these activities and exposures that have caused major epigenetic changes and also unmasked variants that are detrimental to the functioning of the body. So what we're already seeing for neuroimmune triggers, and instead of just talking about mast cells, I'm really going to narrow down to the neuro-mast cell connection in the connective tissue. There are receptors that have been identified on the mast cells that are also on the nerves. And instead of thinking about the mast cells being downstream, they're much more proximal to the borders because that's their job. Their job is surveillance and response. And one of the major surveillance communications is the somatosensory network, where they actually have receptors. The nerves themselves have receptors that can recognize dust mites, can recognize bacterial components, and that will tickle the mast cells through substance P, through CGRP, to increase their activation and change their secretion patterns. And some of the triggers, again, are microbiota and biotoxins. We have physical changes, including all these triggers that are known to happen in individuals that have chronic inducible urticaria or chronic inducible asthma exacerbations. And then we have manufactured chemicals that are stripping the barriers and exposing that neuroimmune network to heighten their danger alarm, and then start causing a increase in release of chemical mediators that are supposed to contain dangers and also remodel the tissue to isolate dangers away from the rest of the body. So the question I'm now posing is there something in our environment interacting on that network, again, that triad of the connective tissue, the nerves, and the compartments of the immune system, including mast cells, that go from acute to chronic neuroinflammation. And this neuroinflammation is now leading to compromise of the central nervous system. And then another question I would ask, and I would defer to our neurosurgery and pathology experts present at this meeting, can you point to vulnerable areas in the spinal cord, for instance, that may be more susceptible to the activities of this neuroimmune dysregulation, especially, for instance, the cervical spine, as well as the pelvis and the lumbar sacral spine, which may be more at risk for pressure changes that can also activate that neuroimmune axis. And so to kind of give you an example of a patient where I had to kind of reverse my thinking on what was going on. This was a child that presented to me in 2011. Again, fairly normal childhood with the exception of susceptibility to migraine headaches, rhinitis, had some sensory issues for which she required PT and OT. And also because she was dealing with hypersensorality, it's very easy to identify some of these patients that are having hypersensorality issues. You just ask them, how do you do with your brother clicking his pen or chewing near you? And they're like, I can't stand it. It's as though their nervous system is just staying on a higher alert. But she was actually, with these interventions by her parents who had the resources to implement these therapies for the child, she actually did okay until she got a bad infection. And the bad infection led to her having increased fatigue and also increased gastrointestinal distress. And you can imagine, okay, in our siloed healthcare system, she goes to GI after GI after GI. They try histamine blockers. They try tricyclic agents. They try changing her diet. Nothing happened. They underwent endoscopies, and unless you ask for look at mast cells with special stains, you won't see them. She saw there was her everything, all the tests were within normal parameters, not giving a clue of what was contributing to her symptoms. And unfortunately, in this society, in our healthcare system, if you can't measure it, it doesn't exist. So many of these patients get assigned psychosomatic disorders, and this is exactly what had happened with her. She had went through the merry-go-round of different practitioners who failed to identify any pathology. And so essentially she was put into a eating disorder program where they forced her to eat. She actually was physically restrained with both, at age 12, she was physically restrained first with, soft restraints, but because she was hypermobile, she was able to slip out of them. So they actually used, nurses to restrain her as she was getting force feedings. And after about 5 days, where there was no relief of her pain, they released her, and she actually underwent an evaluation. She was able to return back to me, and I was able to find that she had a tryptase of 12. And as it turns out, she had the genetic disorder of hyperalpha-tryptasemia, which is considered a mast cell disease problem. And she ended up undergoing an evaluation regarding her spinal cord, and she was found to have occult tethered cord syndrome. So it was her migraines, her rhinitis, her gastrointestinal distress that led to us finding that tryptase that was barely above the upper limit of normal. And that led to us looking for seeing whether or not she had evidence of connective tissue disease. And with the connective tissue disease, we were able to refer her to Dr. Petra Klinge, who found that she had occult tethered cord. And just to kind of lean into the symptomatology that's associated with having this extra copy number of the tryptase gene, these individuals were found to have irritable bowel syndrome, cutaneous complaints such as flushing or itch, connective tissue abnormalities such as hypermobility, as well as autonomic dysfunction. And I can tell you within 3 days of her having her occult tethered cord released, her nausea and gastrointestinal distress was gone. So talking about or leaning more into the crosstalk between the autonomic nervous system as well as the mast cell compartment, it's been demonstrated, whether you're talking GI, you're talking respiratory, if you cause an imbalance in the adrenergic and cholinergic tone, you can actually cause more inflammation. This is an article by Matoli and Boxenstan, sorry if I mispronounced, showing that if you have any issues with the cervical spine, you can end up having less vagal tone, and then you'll end up having more hypersensitivity issues as well as motility issues in the gastrointestinal tract. And the same can be said for Syringomyelia. So basically interrupting and leading to that imbalance between the adrenergic and the cholinergic arms of the autonomic nervous system, you can then end up with you'll end up with an imbalance in the homeostasis between the mast cells staying quiet or not. And the thing about mast cells, you don't want those chemicals out there unless you really need them. And if they do go out there, they have the ability to directly modify the connective tissue, call in inappropriate help, like what Dr. Abionia at Cincinnati Children's identified in individuals that had connective tissue issues, who are 3 times as likely to have eosinophilic gastrointestinal disease. So at this point, I'm just going to kind of break down some of the observations that we've seen over the past 10 years that hopefully will lead to better questions asked and then possibly better therapies besides surgical interventions. And so the first thing would be, what are the signs and symptoms that would warrant multi-system evaluations? And in many ways, we have to kind of step outside of our areas of expertise just to ask the questions, not necessarily evaluate it, just to ask the questions so then you can then refer them to somebody who can run with that baton a little bit further. We're in an age of increased intolerance, both in the nervous system compartment as well as the immune compartment, in the form of immediate hypersensitivity disorders, which are classic mast cell diseases. And this includes interstitial cystitis, pain syndromes, as well as neuropsychiatric disorders, as well as autoimmune diseases. So I hope you can take from this conversation that it seems that individuals that have connective tissue issues have this chronic neuroinflammatory dysregulation going on. And it's important to identify individuals that are having hypersensitivity issues to evaluate them for connective tissue issues and autonomic dysfunction, and vice versa. So in many ways, the neuroimmune system is our first line of tissue defense. They both have components to recognize the usual suspects. Mast cells are clever cells in that they will release certain patterns of chemical mediators depending on what the perceived danger is. And then after the danger has been contained, they now have a set of chemicals that will help with clearance and tissue remodeling and healing. And this is just to emphasize the role of mast cells in secreting factors to help with vasodilation, as well as vasoconstriction to help again with the tissue repair just as much as the tissue defense. So what I think might be going on is that we're having a neuroimmune system that's not turning off. And this has been proposed in individuals in the allergy immunology world, in that, is there a problem with the epithelial barrier and the exposures that we're seeing that is leading to this increased risk of immediate and delayed hypersensitivity disorders, as well as other chronic conditions? And it points to this yin-yang of, if the immune system is balanced and the nervous system is balanced, you have great innate immune defenses and you have a balanced wound healing process. But if it's not, you can end up with pathology and also possibly increased risk to cancer as well. So we're at the point of, I think it's this neuroimmune balance happening in individuals that have connective tissue issues. What's the chicken and what's the egg? We still need to ask that question. But I would have to say that what we're seeing in this change, revolution of our environment and how we live, we're seeing immune dysregulation, we're seeing the unmasking of disorders of connective tissue, as well as neuropathic issues as well. And I will leave it at this point in time saying that I am extremely grateful for the patients being patient with me as well as with the process, because it takes a minute to try to take a step back and absorb all this information. I have had the pleasure of working with some wonderful colleagues, including those that are attending the conference at this point in time, and also the support of both the Bobby Jones Chiari Syringomyelia Society, the Ehlers-Danlos Society, as well as the National Medical Association. And these are just some resources that I think you might find helpful.